We are live, sir. Go ahead.
Okay, thank you so much. So, good evening, all the faculty members and the respected delegates who have joined through online and physical meetings to this scientific session titled ESOC 2023 Breakouts. We know that European Stroke Organization Conference has recently concluded in May 2023. And this scientific session is mainly focused on the top updates from ESOC from our key experts who are present in this webinar. And this will also focus especially on tenecteplase in stroke thrombolysis, a paradigm shift. So we can see through this webinar, there are a lot of practice changing updates which are presented at ESOC conference, which was held in Germany from May 24 to 26. And in this conference, more than 80 late-breaking abstracts were presented in this conference, which are some of which are practice changing and are meaningful to the current practice of stroke, which is practiced currently. And there were more than 1,500 abstracts in the abstract book, which is a more than 600 page abstract book, which were presented in this ESCC conference. So a lot of updates in stroke in different areas of stroke. And this all can be actually accessed from European Stroke Journal also for important reading. But today, what we will be doing in this webinar is our key experts today will be focusing on the important abstracts related to tenecteplase and some other abstracts which are selected. And also we will have discussion on that abstract, and later we can take a question answer session and we will have an interesting panel discussion. So I'm pleased to introduce our faculty for today. Our speaker for today is Dr. Ichapuria sir. Sir is the Director Neurology at Sahyadri Hospital, Nagar Road, Pune. Sir has the first neuro ICU and neuro intensive care of Pune. Sir has been pioneer in stroke thrombolysis in India. Sir has delivered more than 300 public lectures and workshops on stroke. Member of Indian Stroke Association, organizing president of StrokeCon 2012 and many other conferences. Founder of Pune Stroke Group, ex-president of Society of Neurosciences, Pune and Maharashtra Academy of Neurology, principal investigator for many multicentric stroke trials, and awarded as health icon by Times of India. So thank you, sir, for joining today and accepting invite as a speaker for today's ESOC updates.
Thank you. Thank you.
We are pleased to introduce Dr. Subhash Kaul, sir. So he's the moderator for today's webinar. So he's a senior consultant and stroke specialist at KIMS Foundation Research Center, Secunderabad. Has been faculty for more than 3 decades at NIMS Hyderabad. Former professor and head Department of Neurology and deans at NIMS. So has more than 120 publications to his credit in international and national journals. Has been principal and co-investigator of several international and national projects. Has been awarded as a State Teacher Award by Telangana government in 2017. Has held many important positions like the past president of AP Neuroscientist Association, past president of Indian Stroke Association, and past president of Indian Academy of Neurology. Thank you, sir, for joining, and welcome to this webinar. I'm also pleased to and honored to introduce Dr. P.N. Shailaja ma'am. Ma'am is a professor and head of neurology in charge comprehensive stroke care program at Sri Chitra Trivandrum. Ma'am has done stroke fellowship from University of Calgary in 2006 and has more than 180 publications to her credit and 14 book chapters. Past president of Indian Stroke Association, honorary clinical professor, University of Lancashire, UK. Ma'am is a member of Task Force of Non-Communicable Diseases Division of ICMR, member of GBD Cardiovascular Diseases Stroke Working Group, Global Co-Chair, South Asia Mission Thrombectomy 2022, Educational Committee member, WSO from 2017 to 19, Technical Consultant of Stroke Care Activities, Government of Kerala, and also a CME conveyor of Indian Academy of Neurology. Ma'am recently came from ESOC, Germany, and where ma'am has presented some of her important papers. So we are really privileged to hear from ma'am directly about how the ESOC went, and we'll have more interesting updates in this webinar. So the flow of the program will be that I would request Dr. N.R. Ichapuria sir to first give a 30 minutes overview on the tenecteplase in stroke thrombolysis, a paradigm shift, important updates from ESOC. And then it would be followed by panel discussion, which would be moderated by Dr. Subhash Kaul sir. And panelists would be again Dr. Ichapuria sir and Dr. Shaila ma'am. And then we can take questions from audience in this interactive session, where we would be answering, where the experts would be answering the questions from the audience. So I hand over to Dr. Subhash Kaul sir for his opening remark, please. Thank you. So please unmute, sir.
Yeah, thank you, Ankush. All the speaker, Mr. Dr. Ichapuria, Shailaja. So this is basically.
We can't hear.
Hello, you can't hear? Hello.
Yeah, now it's better.
Better or all right?
Yeah, it's good.
Yeah, okay. Dr. Ichapuria, welcome to the
Thank
meeting.
you.
And I thank the organizers, and I think Shailaja is there and all the delegates. I think this is a very interesting meeting. Basically, it's a meeting, it's an update meeting in which we are going through the main abstracts which were presented in the European conference, stroke conference recently held in Germany, and we are focused on tenecteplase here. And one of the reasons is that tenecteplase made a late entry into the thrombolysis field, and we always are comparing it with alteplase and how better it is, how worse it is, what are the advantages. So we have been very closely watching it, and one of the important things is that this whole use of tenecteplase began in India, and we are very interested in seeing what is happening all over the world and know their experiences and then see how it is applicable in our own country. So Dr. Ichapuria is an extremely, thoughtful, observational, practical neurologist who will give us the summary of all the studies which were presented there, and later on we'll have some discussion. And if there are any questions from the audience, they can also keep them down so that we can discuss those also. Over to Dr. Ichapuria, please.
Yeah, thank you, Dr. Subhash, for the kind words. And yeah, I'll just share my screen. Yeah, can you see and hear me?
We can hear, but we can see you, but not the slides.
Oh, okay. 1 second. Share screen. Yeah, now?
Yes.
Yeah. So, as mentioned, there are lots of studies, and we'll have to go through them very fast. And I'll just go through most of them. I'll just go through the conclusions, because then to go into detail of each study will take 4 or 5 hours. So we'll go through very quickly. And very importantly, this ACT trial, which was done in Canada by Bijoy Menon and his group, that will form the main part of today's talk. And then there are some other smaller talks which are also very important. But a lot of subgroup analysis in the ACT trial, it was found that tenecteplase was non-inferior to alteplase. Now, this word non-inferior, the trial was designed to show that it is non-inferior. The trial was not designed to show that it was superior. So we must understand this, that the trial was designed in such a way that it was shown to be non-inferior, and it met the criteria for non-inferiority, though there was a signal that it was slightly superior to alteplase in many respects. However, you must understand that the trial is not designed to show that it was superior. So that will have to be a different trial and a different larger cohort of patients. So please understand this very important distinction. So the first point, these are all subgroups. I think they are very important and very interesting.
So you can make the slides full screen. It's not on full screen.
Say that again.
The slides are not on full screen.
Okay, I'll do that. Yeah. Is that better now?
Yes, sir.
Yeah. So the first the subgroup analysis was safety and efficacy of tenecteplase versus alteplase in acute stroke patients with carotid tandem lesions. The results of the ACT trial. Now, as I told you, I'm not going into the details. Look at the conclusions. In patients with carotid tandem lesions, what do you mean by carotid tandem lesion? It means that there is a lesion in the carotid artery in the neck, and there is another lesion in the brain in the MCA or in the distal ICA. So in patients with carotid tandem lesions treated with endovascular treatment, intravenous tenecteplase is associated with similar clinical safety and angiographic outcomes as compared to alteplase. So here it is the same. Then intracranial hemorrhage patterns and association with clinical outcome in acute stroke treated with tenecteplase versus alteplase. Conclusion: the patients with any ICH on follow-up and those with increasing volume or mass effect were associated with worse functional outcomes in the ACT trial. This relationship was similar between tenecteplase and alteplase. So more or less it is the same for intracerebral hemorrhage, mass effect, and increasing volume of the hemorrhage or the infarct. So both are more or less the same. Now, this is very interesting. Incidence and impact of thrombus migration before endovascular treatment. Now, you know what happens when you give IVT intravenous, the clot, if it was in the M1 segment, it dissolves a little bit, but goes and sticks in the M2 or M3 segment. So what happens to these patients? I never thought of this, really, but recently we had a case and this clot migration occurred from M1 to M2. So intravenous tenecteplase is associated with a higher rate of thrombus migration before EVT compared to alteplase. So more cases, the clot dissolves and goes into the more distal vessels. And thrombus migration is associated with better clinical outcomes regardless of the thrombolytic agent used. So if clot migration occurs from M1 to M2 or M3, the prognosis of such patients is better. And whether you give alteplase or tenecteplase, it makes no difference. But tenecteplase, the chances that this will happen is more than alteplase. So this is very important to think about. Safety of tenecteplase as compared to alteplase in older patients, a secondary analysis from the trial. So now, this thing of less than 80 or more than 80 or younger patients. So in elderly stroke population, tenecteplase had similar safety and efficacy outcomes as compared to tenecteplase. So it was safe in elderly patients into the 80s and even into the 90s. So it is a safe drug to use. Intravenous tenecteplase compared with alteplase for minor ischemic stroke. For patients enrolled in the ACT trial presenting with minor stroke, tenecteplase was as effective and safe as alteplase, and there were fewer deaths at 90 days in those treated with tenecteplase. Now, our constant worry is that if it is a minor stroke and we are giving thrombolysis, the patient may bleed. And, that minor stroke will get converted into something that, we cannot handle. So this is a constant worry with all of us. So therefore, very minor strokes, maybe we would not treat. But here it has been found that it was effective and safe as alteplase, but there were fewer deaths at 90 days in those treated with tenecteplase. So this is also an important consideration. White matter lesions. Now, 1 second. I can't see this. Yeah. one second, we'll go back. Association of white matter lesions in patients receiving alteplase and tenecteplase. Now, Subhash also was telling me that we are always worried that, there are a lot of white matter lesions. So there's microangiopathy, and is it safe to give these drugs? So it's not as safe. But in this large pragmatic trial, white matter disease was associated with worse functional outcomes after thrombolysis, but was not independently associated with symptomatic ICH or mortality, regardless of the thrombolytic agent used. So they don't do so well, but they are equal as far as the thrombolytic agent is concerned, because already the brain is damaged, and their prognosis may not be so good. So this is straightforward. They compared in various sexes, and it was found to be equal. So we won't go into more detail here. Now, quality of life. Quality of life after thrombolysis in acute ischemic stroke. Now, we are always worried about quality of life. So tenecteplase offers comparable health-related quality of life benefit as alteplase in acute stroke patients. However, there remains sex and age-related disparities in health-related quality of life regardless of the type of thrombolysis used. So quality of life improves with both the drugs, and they are more or less the same. Influence of age we've gone through, but one important thing is in this trial regarding age, that tenecteplase is as effective and safe as alteplase across all age groups, but may have additional benefit in younger people with ischemic stroke. So this is another, there are small increments. There are small increments as we go along. So, these small increments may all add up. So we'll come to these small increments which occur with tenecteplase. Now, cognitive outcomes in patients with alteplase and tenecteplase. No difference in cognitive outcomes were noted between patients with RTPA or TNK. In both the groups, the majority of patients exhibited cognitive impairment on the MOCA, despite high prevalence of good outcomes. Now, this is very important. We always say that patient has improved and his MRS has come to 2 or 1, and we show that the patient's hands are going up and he's walking. But we are not assessing their cognitive function. And the cognitive function after stroke, in most patients, there is a decline. So even, MRS is not able to capture the real quality of life improvement which occurs. So quality of life and especially cognitive impairment goes down after stroke, and there is a high prevalence of cognitive decline. So this is also very important. And both the drugs, they found that there is no difference. If the vessel opens up and the person reaches MRS 1, 2, 3, it's equal, but cognitive impairment is very important, and we must think about it and study it a little more than we are. Now, again, in posterior circulation strokes, no difference between tenecteplase and alteplase. These are not all the worries, that, it's not been studied enough. There are subgroups where alteplase would be better. But, this ACT trial and this subgroup has shown that across the board, both are more or less equal, and maybe a slight shift to benefit. In medium vessel occlusion, intravenous tenecteplase, comparable safety and functional outcome compared to alteplase. So large vessel is there, medium vessel is there. So medium vessel also, both are equal. So what are the conclusions? And Subhash, I think after this we can discuss some of these, and before we go on, because then it will otherwise get very complicated. So in an elderly stroke population, TNK had similar effect as compared to alteplase. In patients with minor stroke, TNK was as effective and safe, but there were fewer deaths at 90 days with tenecteplase. Tenecteplase is effective and safe in as effective and safe as alteplase across age groups, but may have additional benefit in younger stroke. Younger means less than 80, by the way, not 40. Intravenous tenecteplase had similar effect as outcome as alteplase without increased safety risk in posterior circulation strokes. Intravenous TNK had comparable safety and functional outcome compared to alteplase amongst medium vessel occlusion. Tenecteplase had comparable health-related quality of life benefit as alteplase in acute stroke patients. ACT trial demonstrated comparable functional safety and angiographic outcomes by sex, and this effect was the same between the two. So, shall we just go on, or you want to stop, Subhash?
I think up to this we can discuss. So what are your impressions? Has it further reinforced your faith in tenecteplase, and do you think this data is going to make some difference in the acceptability of this thrombolytic agent in India?
Yeah, see, the worry was that whether this drug is as good as alteplase. And I think this ACT trial has shown that it is as good. Maybe an edge in younger patients, maybe an edge as regards cost. And of course, there is a cost in India. Cost in India is lesser because it is a biosimilar drug. So I don't know if there's a cost advantage in Western countries, but in India, definitely. And of course, the biggest advantage being ease of administration. And another thing that has come out is that in minor stroke, the risk of hemorrhage is lesser. And in younger people, it may have there is a signal that it may have better outcomes also.
Yeah, I think I completely agree with you. I mean, that is most of the places it's saying it's equivalent to alteplase, which itself is, which we know, but it just reinforces it, that it's, and the fact that it is cheaper and economical, anybody will use it because it's equal to alteplase. But in some things, it's even better, and one of them is the young age. And you've got a young age. And the second thing I was very interested is in this thrombus migration, Dr. Chapuria. This I always used to think thrombus migration is bad, actually. Because some of my patients have worsened after thrombus migration. Means you give them TPA, they improve, or any thrombolytic, they improve, and after that suddenly they go down. And it turns out that the thrombolytic agent had broken the clot, and then it had gone. It used to happen in some of these patients. Actually, the clot was in the heart. And it had fragmented the clot, but sometimes it was even in the proximal large vessel broken it. But from this study, it seems that it has correlated with the good outcome.
Yes.
Yeah.
And tenecteplase has an edge over alteplase.
So that's the important thing. Maybe the ones which we have seen are only part of the iceberg, tip of the iceberg. Maybe most of them actually it's a good thing. After all, that is the mechanism by which these agents work. They fragment it. Maybe the ones which we have seen are tip of the iceberg, the big fragments. Probably it is expected to break them into very small fragments and dissolve them and displace them quite distally so that they don't interfere with the circulation. So that's a good insight which has come
that is
from this.
That I found very interesting, as you said, this clot migration. We had not thought of it so much.
Yeah.
But now, after reading this, it became very clear that this clot migration may be a good thing, because from a big vessel, it goes into a small vessel. So, the area of infarction or area of damage is definitely limited. And sometimes you can take it out by MT. Sometimes you don't need to take it out by MT. So...
and I also agree with you, Dr. Chapuria, that minor strokes, even though they are minor, they can be a bugbear. Because that question always comes that should we have thrombolized it? Should we thrombolize it? After all, it's a minor stroke. And the PRISM trial, which was done at that time by Pooja Khatri's trial, which was prematurely terminated. They had used the alteplase, and in that they said that no, there is some 3% chance of bleed and all. That's why it should not be thrombolyzed. But it's good to see here that minor strokes are done well with tenecteplase. And so next time we have a minor stroke, we can very confidently give him IV tenecteplase.
Yeah.
And
Good points.
I mean, I completely agree with all the points which you have said. And mostly, I think the summary is that it's not inferior in any way to alteplase. In some ways, it may have even an edge over it. But the points which they have seen are very important in a stroke patient, which you have already said. I'm only repeating, like white matter disease. We're always afraid of it. Like these small vessels, or medium-sized vessels. Normally, our whole concentration is on the larger vessels, but the medium-sized vessels and the PCA strokes, and the most important, the cognitive outcome, which you so emphatically said that cognitive outcomes also should be seen, and it has been seen. Makes a difference in the cognitive outcome also. So that's very nice, and we can move to the second part of the.
Yeah. Now this is very important trial, and we were always very concerned with these large strokes, so with low diffusion weighted imaging Alberta stroke, that means aspect score in early CT scan. So if, we always used to say that if the aspect score is high, that means more than 6, it will be beneficial. But if the aspect score is 2, 3, will it be beneficial? So, and there was often, it was initially quoted that it was a contraindication to give thrombolysis for these patients. But now this has changed drastically, and as we'll go along, we'll just see that, number of trials have shown that even with large with low aspect score and large infarcts, there is some benefit of thrombolysis and of MT. So bridging therapy, so this trial, bridging therapy with tenecteplase or alteplase in patients with low diffusion weighted imaging aspect score. The data are reassuring, conclusion. The data are reassuring regarding the safety and efficacy of tenecteplase as compared to alteplase in bridging therapy for patients of LVOs and large ischemic core in routine practice. So it is reasonably safe. The risk of parenchymal hemorrhage is low. It's not that it's not there, it's there. But anyway, if you did not treat these patients, anyway, they would not do well. They would either die or they would be severely disabled. So this showed that, there was decrease in disability in about 20% of patients. So I think it's very, very important. Now, this is very.
Is it sorry, Chapoli?
Yeah.
Can we go? This is a very important. Can you go back to that study? Yeah. So when they say reduced disability at 3 months, this is compared to those who did not get.
Yeah.
Prevention.
Right? So there is a sorry. There is a definite advantage. I don't know how much advantage, but they say about 20% advantage. Now, what exactly is meant by 20, I don't know. But it's not a contraindication. That is one. And there can be some benefit of treating these large strokes with tenecteplase followed by, if there's an LVO, then followed by MT.
No, this is about this is the low diffusion weight you are talking.
Huh?
These are the small infarcts, low diffusion weighted imaging with a large vessel occlusion. I think that is the group.
No, low Alberta score. Low aspect score.
Okay, low aspect score.
Low aspect score. Okay. That means big stroke.
Okay, correct, got it.
Yeah. Okay. So we'll come back to this point again, because this is a very important point. Very important.
Big strokes. You mean big strokes?
Big strokes. Now look at this. I'll just, this thing is creating problem for me. Yeah, just minimize this. Yeah. Cost effectiveness of tenecteplase versus alteplase for stroke thrombolysis evaluation trial in the ambulance trial. Treatment of ischemic conclusion. Treatment of the ischemic stroke patients with tenecteplase was shown to be cost effective and improves quality of life in the mobile stroke unit setting. The reduced total cost from tenecteplase was driven by savings from acute hospitalization and reduced need for nursing home care. So these patients, because they were treated in mobile stroke units, so they were treated outside the hospital, but we don't have too many of these mobile stroke units, and it's not well established in India. So we don't know yet, but many Western countries, these the mobile stroke units are getting more and more active, and data is coming out. And it has been found that these mobile stroke units are using tenecteplase quite a lot, and they have been found to be cost effective, and they reduce the hospitalization duration and the nursing home care. So distinct advantage in the mobile stroke units, distinct advantage.
Okay.
Okay. No, it's not moving. Why is it not moving? Okay. Yeah. Early recanalization among patients undergoing bridging therapy with tenecteplase or alteplase, a propensity matched analysis. Now, this is very interesting. Both thrombolytics achieved ER. ER means recanalization of in a fifth of LVO patients. That means about 20%, with no interaction found among known predictors of recanalization. However, recanalization was 4 times more likely with tenecteplase when evaluated within 30 minutes after IVT. Now, here what happens is, because you are giving a bolus, whereas alteplase will take 1 hour for the treatment to get completed. So really, when you assess at 30 minutes, it is 4 times more likely with tenecteplase. So, you are saving quite a bit of brain because your door to needle time or door to treatment completion time is also lesser. So 4 times more likely with tenecteplase when compared to alteplase. So this, I think, is a distinct advantage of and we have seen this in our clinical practice. We have seen this umpteen number of times in our clinical practice. Now, cost effectiveness of tenecteplase versus alteplase for acute ischemic stroke. Tenecteplase treatment was cost effective for all AIS patients and AIS patients with LVO compared to alteplase. This finding supports broader use of tenecteplase in the acute stroke setting. Now, here I just want you to look at these figures. Oops, sorry. Yeah, these figures are very important. If you see total quality, that is cost effectiveness, you are saving 50,000 euros over a 10-year period. 50,000 euros. So it improves in the acute stage. You save 21 euros per patient. But over a period of time, you save 2,300 euros, and rendering tenecteplase cost effective as compared to alteplase. And we have found this in our practice also, that cost effectiveness, and we want to deliver at the cheapest possible cost, because many of our patients are not able to afford. We are a developing country, low medium income, so cost is important in even rich countries. Everywhere it's important, but even more important in our countries. And really, what you save finally is 50,000 euros. I think it's fantastic. So I don't know how they've calculated it. It's a little complicated how they've calculated it, but whatever the calculation is, it is cost effective. So I think this point, Subhash, you want to say something on this point?
No, it's quite self-explanatory. We know it. I think in India, we know it more than anybody else. It's quite obvious.
Yeah. So this is in the mobile stroke unit. This is important for us, to just understand what has happened, what is happening in the world. So conclusion is, several mobile stroke units have been adopting TNK 0.25 milligram per kilogram as the agent of choice for acute stroke thrombolysis. The majority of MSUs using TNA are not enrolled in active ongoing clinical trials. These results indicate that the decision to transition to TNK was influenced by its practical advantages and promising scientific data to date. So it's very promising, Of course, we know that, the ease of administration in the ambulance is a major advantage. But in spite of the ease of administration, that is one thing. But even then, it is found to be, even if you discount that, it is found to be beneficial. Tenecteplase versus alteplase before thrombectomy, a comprehensive clinical and angiographic impact. Tenecteplase showed no better clinical or angiographic impact for thrombectomy compared to alteplase. Nevertheless, it seems superior to shorten thrombolysis to groin puncture time. Okay, so I think both are equal. My experience personally is that it opens LVOs much better than alteplase, but that's my small experience. I haven't done a study, but this is my personal view, and I would like to know the view of other people, from all over India, what their view is. But certainly it shortens the groin to puncture time, and even if it does that, the outcome should be better. Safety of tenecteplase versus alteplase in stent implantation in the acute ischemic stroke. Now, these, in India, we have these ICAD quite commonly. So many times, after doing thrombectomy, you have to put in a stent into the carotid artery or into the MCA or even into the basilar. In their series, the use of TNK prior to mechanical thrombectomy with stent implantation in the acute phase of stroke was shown to be safe and did not significantly increase the risk of symptomatic intracranial hemorrhage. So it is pretty safe. So finally, these points are there. I'll just go through them. Tenecteplase was found to be cost-effective and improve quality of life. Reduced total cost from tenecteplase was driven by savings from acute hospitalization and reduced need for nursing home care. Early recanalization was 4 times more likely with tenecteplase when evaluated within 30 minutes after IVT. And tenecteplase treatment was cost-effective for all AIS patients and AIS patients with LVO compared to alteplase. Okay. Now, this is a very important trial called the Timeless trial. Now, what does this show? Now, this is a late-breaking abstract. Efficacy and safety of tenecteplase in patients with late window acute ischemic stroke and evidence of salvageable tissue. Results from phase 3 Timeless trial. That means the patients who presented 4.5 to 24 hours after last known being well. So it was really in the late window. And what were the conclusions? This is how the trial was done. This, I think, we need to just elaborate a little more. So the one group of patients, 230, where it was outside the window, conventional window. So only placebo was given. Some had MT, some had no MT. Okay, and some were given tenecteplase at 0.25 milligram per kilogram. That means 4.5 to 24 hours. Remember this. And of course, some did not receive MT, some received MT. Both were comparable in numbers, if you see. And what did it show? It showed that there seems to be a little shift, but if you see statistically, according to me, there is a little shift, but statistically, there was no difference in the odds of lower MRS at 90 days. So actually, it was a negative trial in that way. But these are the conclusions. The primary and secondary efficacy points, favorable shift in MRS and MRS 0 to 2 were not met. Tenecteplase versus placebo. And but if you see, there is a little shift. MRS 0 to 2 is 46%, and in placebo, it's 42%. Complete recanalization at 24 hours was increased in the tenecteplase group, 77% versus placebo. And interesting findings from pre-specified subgroups, time from study drug administration to femoral puncture was relatively short, 20 minutes, but no apparent advantage of longer dwell times. M1 occlusions suggested a trend to improve treatment response versus ICA or M2. Further investigation is needed. No safety concerns were identified in the 4.5 to 24-hour treatment window. The number of symptomatic ICH and fatal adverse reactions was low and balanced across the treatment arms. So conclusion is that it is safe. We used to think that it is not safe. So it is safe. The number of ICHs were not increased. And there was a signal that perhaps it was beneficial. I mean, it's not reached statistical significance. And maybe in subgroup M1 did better. So, if we analyze M1 separately and M2 separately and ICA separately, there is a signal that in M2, it may be better. And we may be able to do femoral puncture earlier in the tenecteplase group. So this is very important, this safety aspect. Though the trial is negative, there is a signal. So there is one person, Georgios, these Greek names, Sisagolis, professor of neurology at University of Athens, Greece, said that he thought the trial had shown three important results. First, TNK appeared to be safe in this late window in these selected patients. This is a very important observation. Secondly, reperfusion rates at 24 hours were increased with TNK, and we know that this translates into clinical benefit. And third, there was a neutral effect on primary outcomes, but I think the sample size of 438 patients was not large enough to show efficacy. So maybe it is the design of the trial. More patients, first of all, it was safe. And secondly, the reperfusion rates were higher at 24 hours. But the numbers were small, and therefore we could not show efficacy of this particular drug. And therefore it missed the endpoint. So, you should not think that it is a negative trial, because, to get 438 patients, not easy. And maybe with a larger cohort, we may find benefit. So we don't know. But it's an important thing to remember that you can give it after 4.5 hours.
So Dr. Echapuria,
yeah.
You think this is the same, this is the tenecteplase counterpart of Dawn and Diffuse trial going up to 24 hours?
Yeah.
Almost.
But they never gave thrombolytics, they did direct MT.
That also they have done. Some people have received there also, those who entered within 4.5 hours. Basically, the concept is to extend the window.
All the time we were saying that, after 4.5 hours, don't give thrombolytic. Take directly.
Yeah.
But now we can say that, no, you can give, and nothing really adverse happens.
Correct.
So, it's fantastic, how things are changing. So here it is, another one, this from India. Efficacy and safety of injection of tenecteplase into 4.5 to 24 hours imaging eligible window patients with acute ischemic stroke. This is an ongoing trial and we don't have the results yet.
So this is the same thing which we are doing in the Indian setting. Almost the same thing.
But it's very good, that they are doing it. Now look at this, tenecteplase in central retinal artery occlusion, phase 3 trial. They want to have 78 patients. Oh, it's so difficult to have 78 patients of central retinal artery occlusion who come within 3 to 4 hours. My God, I don't know how they are going to get, but when they get it, I think it will be very important because, randomly people are giving, even I've given, but, many of them come after 24 hours or ophthalmologist refers very late. So, we can't give it. So I think this is a very important trial for tenecteplase for central retinal artery occlusion. So we are eagerly waiting for this. So this is another trial, the tenecteplase after revascularization. So, giving the drug intra-arterially after the mechanical thrombectomy for the residual, if the full recanalization has not occurred. So this trial will be completed. Results are awaited. Yeah, non-large vessel. So this trial also is coming up, resilient. So these are all trials which are coming up. So a lot of new work is going to come up in the next 6 months to 1 year. Intra-arterial tenecteplase for non-complete reperfusion of intracranial occlusions. So I'm just telling you what things, a lot of work is going on. So, it's fantastic. So beyond 4.5 hours also people are using. So TRACE 3 will provide evidence for efficacy and safety of TNK TPA in patients who had ischemic stroke due to anterior circulation, LVO, beyond 4.5 hours. So whole paradigm shift has occurred. So even if timeless trial does not meet the endpoints, 24 hours, it was increased in TNK group, no safety concerns, ongoing trials are there. So we will get more data as we go along, but it looks so very promising. So I don't think we'll go into all this because already time is getting short. But now, this point of these large infarcts with low aspect score. So there was this meta-analysis of SELECT2, Rescue Japan, Limit trial, Angels aspect trial. These trials were done in China, and then SELECT2 was done, I think, in Europe, and now as Rescue has come. So and now this Tesla trial. So all these trials, what are they showing? So I'll just read these things because they're very important and it's really practice changing. Although not quite meeting its primary endpoint, the new trial Tesla has added evidence suggesting that patients with large ischemic strokes who have a significant amount of brain tissue damage may still benefit from thrombectomy. And a new meta-analysis, MAGNA, of previous studies in a similar population has provided more detailed estimates of the treatment benefit of thrombectomy in these patients. So there is benefit. The Tesla trial, which included patients with large core infarcts, aspect 2 to 5 within 24 hours of symptom onset, showed encouraging trends towards a benefit with thrombectomy for the primary outcome at 90 days scores and the modified ranking scale, but did not reach the pre-specified Bayesian superiority threshold. So it did not reach that threshold. Several secondary efficacy endpoints also showed suggestions of benefit for thrombectomy. So there is a slight, my conclusion is that there is a slight benefit. It's not a great benefit, but there is a slight benefit.
Yeah.
So I won't go into all these, but finally, it has been shown that patients with large core infarcts can still benefit from endovascular thrombectomy. So this, in a way, is practice changing because we were rejecting these patients. In the DAWN and DIFFUSE trial, we were rejecting these patients. And I had given a lecture last year, and I said that only 5 to 10% of patients in the 4.5 to 24 hours can meet the Dawn criteria or diffuse criteria, and only those should be taken. But now these studies have shown that even large infarct or with low aspect score, they also can be taken. And though the benefit will not be great, it will not be fantastic, but there will be some benefit. And maybe, they'll come to an MRS of 3 or so. They won't come to 0 and they won't come to 1, but some benefit will be there. So we should keep our minds open. We should talk to the family and decide. So some benefit is there, no great benefit, but definitely some benefit. Yeah. So, this Tesla trial, what is important is that they did non-contrast CT scan. They did non-contrast CT scan. They did not do any sophisticated CT scan. So non-contrast CT scan without advanced imaging to select patients and excluding the inclusion criteria with aspect score of 2. Non-contrast CT scans are available at all stroke centers. So this study is more practical, highly generalizable, and more applicable globally. However, our results suggest that when we use non-contrast CT scan only to select patients, the gain or treatment effect of thrombectomy seems to be smaller than when using sophisticated advanced imaging to make the decision for thrombectomy or not, as in other trials. So if you have sophisticated imaging like rapid or perfusion scans and all, definitely your decision taking will be better. But even if you have a plain and simple CT scan, also you can take a decision. It may not be so good, but certainly you can still use it. So this is very, very, I think, amazingly important messages. So I think we'll stop. I won't go into this because then it will become too complicated. Yeah. Effect of blood pressure. I don't think we'll go into that. Blood pressure, Ayurvedic. This trial is from India. Ayurvedic treatment versus general physiotherapy. And this was given by 1 month. This was given by for 1 month, between 1 to 3 months. And it was done in Kerala by Dr. Sailaja. I don't know if she's here.
No, she could not join.
Oh, she could not join. But anyway, this trial showed that Ayurvedic treatment is not superior to physiotherapy in the rehabilitation of patients with ischemic stroke. So we can show this, these many people go to all these Ayurvedic centers and they do all this massage and all this. So this trial, for the first time, I think is a damn good trial. It has shown that this Ayurvedic massage and oils and this and that has not shown to be beneficial over conventional treatment. Yeah, this is another trial done by Dr. Shailaja, plaque imaging. I don't think we'll go into that. Yeah. Now, this, this problem is there, this economic efficacy of mechanical thrombectomy. What is the conclusion? There is striking disparity among countries in economic efficacy in providing access to MT despite similar GDP per capita. Significant determinations of superior economic efficacy, including higher MT operator and center availability, developed pre-hospital systems and MT reimbursement facility. All these are required to make MT really accessible to many people. Now, we are facing this huge problem that many of our patients are not able to get MT because of the lack of reimbursement. Centers are not available, distances are large, telemedicine is not being used, pre-hospital stroke systems are not good. But this disparity is there even in very highly developed countries. So we should not feel too bad about it. I feel very bad about it, but it's there all over the world. I think we'll not go into all this. Okay, thank you so much. I think we've talked a lot for 45 minutes. Yeah, Subhash.
So, no, I think you have really given a very, very, I would say still it was concise what you gave because you have to go through a lot of data. And we have found that most of the one of the main messages is that it is definitely not inferior to alteplase. It always has been a question because alteplase has got so many years of experience and so many years of use, and this is a relatively new molecule. So this year's conference has clearly shown that it's definitely not inferior in any way. In fact, on some counts, it's superior only. So that's one take-home message. And other things they have discussed about the...
Yeah, I would like Dr. Pradeep's comments. Dr. Pradeep,
yes.
please.
Dr. Pradeep. I think Dr. Pradeep was the one who right from the beginning had complete faith in
He is
this.
the pioneer for tenecteplase.
Yeah, when nobody believed it, he was the believer.
Yeah,
So
he was
Pradeep.
a real believer.
Good evening, everybody. Am
Good
I
evening.
audible?
Yes,
Yes,
sir.
sir. Yes, sir.
See, I'm very happy to be associated today. See, I have one or two main things to tell. See, when I don't know, probably Dr. Chiparia might remember. It was 2 years before when we were at Goa.
Yes,
At
I remember very well.
I was pitted against now less than a person called Bernstein.
Yeah.
Bernstein was talking against, and I was for tenecteplase. Okay. And that was a debate, and ultimately Subhash Kaul was also there, and I got almost an 80% vote for my presentation. And then what Bernstein told us, let us wait. The next week, the ICT trial, is coming out. Then we will have a head-on collision. And very next week, the first call after the ICT trial came, Bijay Menon presented it. I got the first call from no less a person than Ichapuria. He called me and congratulated in the morning. Whatever you spoke has come true. So that is what. See, if this trial, instead of us doing, because we did the first phase 3 trial in India on tenecteplase, and if this was done actually in Canada, this molecule would have flown high so many years before. Just happened that we did the first trial. It did not. Ultimately, it had to come as an ACG trial from Calgary to get it accepted world over. We knew all these facts much before. We knew all this. In fact, Ichapuria was just commenting that some areas it is superior, but we definitely know this is a much better, superior molecule than Actylase.
I agree with that.
And Dr. Pradeep, in Canada also, it was done by an Indian only.
Yeah, I know that. Ultimately,
No, but Dr. Pradeep, I certainly feel that it is superior.
It is 100% superior than the other molecules.
I mean, that's personal experience now. Yeah.
In fact, that the story is we were doing only some 800 thrombolysis before this 2016. But now we have already crossed something like 35 to 40,000 thrombolysis within the last 4 or 5 years. So that itself is the proof of the thing that this is a much, much, much better molecule.
So, Dr. Ichapuria, would you, in your practice, based on these findings, some of the results are equivocal and we have to wait for some more time, but based on whatever data is available, would you offer yourself tenecteplase to people who have crossed 4.5 hours? And those who have got big course, what would you do? At this stage?
It's early days, Subhash. I was always unsure, I was always unsure. I was always scared a little bit. And, we were going by the criteria and, by the guidelines. But, guidelines are not written in stone. And you can clearly see now that, everyone used to say that, no, after 4.5 hours, he'll get hemorrhage and die. And then you'll be taken to court and all that. Nothing of that sort. I mean, the results are equal. And there is a trend towards betterment, even after 4.5 up to 24 hours. So we were very skeptical in the beginning, like all usual physicians, and we were scared. But now I think enough data has come to show that even bad strokes and really big infarcts also you can take for IVT followed by MT if required.
Yeah.
And
So there's a-
and another thing by which I think it's not come in this trial, I mean in this group, but recently there was a trial of tirofiban for non-LVO and non if you don't see a vessel occlusion and you cannot give and you cannot do MT, so tirofiban has also been found to be useful up to 24 hours. Now I've not used it too much because but it's a possibility, that instead of just giving aspirin, which may take a long time, or clopidogrel, which may take a long time to get into the system, if you give IV tirofiban over 12 hours and then give aspirin or clopidogrel, it takes little time.
Yeah.
So it may
But I
be
think-
beneficial. So I
but
think that is another area which we must think about.
That's true. But as of now, we cannot use tirofiban in our routine practice because
Yeah.
we need-
That one trial has come, but some people are using it already. And
it's being used in the intervention circles. When they do intervention, that time
Yeah.
they use
that time to we are using. But now this is for IV use when we don't find LVO.
So
And patient has come late, or you cannot give thrombolysis for some reason. So this is a possibility. I don't know. But
Because-
these trials have given us confidence to give it
So
after
we have to look-
4.5
we have
hours
to-
also,
watch with interest.
without much risk.
Dr. Chapuria, there's a question for you. It's from Dr. Makaran from MP. Can we expect extended window for mechanical thrombectomy also? So it's already extended up to 24 hours.
Yeah,
Probably he means beyond 24 hours, up to 72 hours.
Now that, you never know. Today it's 24 hours, tomorrow it may be 48.
Now, the second question is,
and there are anecdotal reports that basilar after 3 days also has improved. So many people have reported. So many people have reported that.
so there's other question. What is the upper cutoff from observation time after IV thrombolysis to see whether there's any clinical improvement before you go for mechanical thrombectomy? I think we don't wait. We just go after we have given. What do you say, Dr. Chapuria?
Yeah, don't wait. No waiting. So that is another advantage of time to place. You just give it and go.
So other question from Dr. Praveen from Hyderabad is, can we take a consent and thrombolyze IV after 4.5 hours?
See, it is not in the guidelines. It is not level 1 evidence. It is about, I think, I don't know how much you would call it. It's not come in the guidelines yet.
Yeah.
But guidelines always take time, studies have to come, guidelines, those old people have to sit and they have to fight. And it takes 2-3 years for the guidelines.
I would agree with you, Dr. Chapuria, not to do it beyond 4.5 hours. But if at all you are very, very much pressurized, then take a consent. Do have some rationale. For instance, look at the flare changes; they should be absent, or ideally do a perfusion scanning. If you can find a diffusion-perfusion mismatch of at least 1.2, then as per the trial results, you can do. But going straight away without doing all these things may be legally problem later on if the patient doesn't do well. Chapuria, what is the next question for you?
This question of this capsular warning syndrome, I find this most difficult treatment, capsular warning syndrome. Now, of course, we thrombolize these patients, but I was thinking, many times we were thinking and discussing in our group that for capsular warning, we should give IV tirofiban. I don't know, there's no data, there's no this thing, but we're just thinking aloud and, we're just discussing with everyone that, this capsular warning, you give IV thrombolysis, again, he gets a stroke, again, 20 times in a day, he makes your life miserable for the next 48 hours. So why not use tirofiban in these cases, So it's a thought. I don't know what you all think. I'm just throwing it up for discussion to everyone,
It will need a clinical trial.
Yeah, I think it will need a trial.
But right now, people are giving IVTPA. A few years back, even IVTPA could not be given.
I've given so many times. I've given IVTPA in this thing capsule.
And in half of them it stops, in other half it doesn't stop.
Yeah.
You know.
So it gives you stress. It gives you a lot of
So
stress.
now one next question for you, Dr. Ichapuria. What are the possible disadvantages of tenecteplase place compared to alteplase? Now,
What
this is
are
a
the
tough one.
possible disadvantages? Dr. Pradeep, just help
Yeah,
me
I
with
will
that.
See, if at all, if you ask, well, there is a disadvantage, there is only one. That is, you have already given the drug. You cannot hold it back. You already used the weapon. Whereas in an actylize, you can always stop the infusion. So because you give only initial 10% as a bolus, subsequently you're giving as infusion. So if you want to stop the infusion for some reason, you can stop it if you want. But with the tenecteplase, you can't do that. But otherwise, there is no other disadvantages for this vis-a-vis actylize.
Yeah,
So-
so suppose he bleeds within 15 minutes. Suppose he bleeds within 15 minutes, you can stop the
That's
actylize.
right.
Whereas,
That's right.
but that
That's right.
situation I've never seen, Dr. Pradeep. I've
I
never seen.
too have not seen.
Yeah,
It's a
we are
theoretical-
just talking
theoretical possibility.
theoretically.
Yeah, that's right.
If they bleed after 1 or 2 hours, 3 hours. But but sometimes this angioneurotic edema comes. I've never seen it really. But if angioneurotic edema comes with actylase, you can stop the drug and give.
Stop the drug.
Now, I've never seen it with tenecteplase, so I don't know really. If I see it, then maybe I'd give adrenaline or steroid or something like that.
So, Ichapuria, this question, can you read? Problem comes when it's an ICAD and we have to stent rescue intraoperative during mechanical thrombectomy with tenecteplase already given.
1 second, let me read that. Problem comes when it's an ICAD and we have to stent rescue intraoperative. Yeah, so that trial was there very clear that there is no risk. You can put in a stent, and when you put in a stent, you can give IV tirofiban. When we've done that many times, because ICAD is common in India. And we have given tenecteplase, then we have done mechanical thrombectomy. Still that vessel keeps on collapsing, so we have to put in a stent.
Yeah, tenecteplase will
then-
not cause a problem.
So there is no risk. Don't worry, nothing is going to happen.
The risk is with the double antiplatelets which we have to give later.
Yeah, later on. Yeah. So I think that, and that trial is also shown, by the way. This is not just my observation.
What are the
else's.
guidelines for tenecteplase in pediatric population? None, I think.
No, just now there are no guidelines. Just now there are no guidelines. See, guidelines take time to come.
So the other thing is, any antidote available for it? Antidote. I don't think that there is any specific antidote either for alteplase or for tenecteplase. We actually just go by the fibrinogen levels. If the fibrinogen level is less than 150, we give cryoprecipitate. As such, there is no specific monoclonal antibody.
Sir, good evening, sir. From Chennai, we have a question to ask. Doctor here, Dr. Jayanti madam is here. Please, ma'am.
Good evening, sir.
Yeah.
Just a doubt. Does the size of the clot help us to differentiate whether we should go in for tenecteplase or alteplase when we see the size of the clot and there is no changes on the CT?
No, there is, see, it's very important. It's an important question. What has been shown is that if the clot length is more than 8 millimeter, it is unlikely to open. It's unlikely to open with IV therapy. Also, another thing that you have to see is clot porosity. If the dye is going into the clot and the clot is porous, it is very likely that it may open up with IV therapy. If the clot is absolutely firm and stiff now, and nothing, the clot is like that, and the drug is only hitting the surface, it's not going to open. But if the clot is porous and little bit of the drug is going through, it's very likely that it may open. So you can see the clot porosity on CT scan, CT angio.
Okay.
You can see the length of the thrombus. If the length of the thrombus is more than 8 millimeter, less chance that it will open up with IV therapy.
Would
Another
a
thing
bridge-
is whether it's a red clot or it's a white clot.
Yeah.
So, if it's a platelet-rich clot or it's a fibrin-rich clot. So
Mhm.
that you can do by seeing the Hounsfield units of the clot on the CT scan, on the plain CT scan. So these things may help you. But I don't, for these LVOs, I am using tenecteplase. And I am finding that tenecteplase in 20, 30, 40% of patients, it is opening up the vessel. And we have to, we can avoid mechanical thrombectomy. Mechanical thrombectomy is a costly affair. Forget about cost, you have to open the cath lab and get the first person. It's not a joke to do mechanical thrombectomy. Patient has to be in ICU. The costs are enormous. And if you can open it up with tenecteplase, which costs 30, 40,000, you have done great service to the patient. I don't know what Subhash and Dr. Pradeep feel about this, but I am very strongly feeling that, you should give tenecteplase and try to open up the clot. And 30, 40% of the time it opens, to our great surprise and delight. And, you have saved so much for the patient and you have done so much good for the patient. Yes, Dr. Pradeep.
Yeah, Dr. Jayanti, good evening. See, actually, I fully agree with what Professor Ichhaburi has told. Actually, in the original NINS trial, if you look at it, if you look at the terminal ICA, the percentage of recanalization with RTPA was only 9%. 9%. See, with the tenecteplase, the study shows it is more than 25 to 30% of a terminal. I'm talking about terminal ICA occlusion. Terminal ICA occlusion. So which definitely tells you that this is a molecule which has to be used, but ideally for a large vessel occlusion, it is for a terminal ICA, it is mechanical thrombectomy most of the times. But if a drug you are using, it has to be tenecteplase.
Yeah, and Dr. Pradeep, it makes sense because it is more fibrin specific, as you have said so many times.
Yeah.
So it will act much more there.
Yeah.
Subhash, what is your experience with tenecteplase for LVO, for MCA?
No, it's good, like yours.
Yeah.
Agree with you.
So, Ma'am Jayanti, I think we should use it and use it, without any fear. Just use it. You'll be surprised and you'll be delighted. I'm telling you, I've been delighted so many times.
But one of the things, Ichhaburi, is coming, one of the things which we face is this 3-hour restriction and 0.2 mg restriction. We really want these windows to go away, and still there is some technical problem that we are stuck at that 3-hour and.
But I think 0.25, I think we are using.
Off-label. We are using it off-label.
Yeah, it's off-label because DCGI has said 0.2 mg per kg. But I think all the trials now, all over the world, DCGI has not updated. All the trials have come around to the conclusion that use 0.25.
They need to update
that Nortest trial was done with 0.4, but bleeding risk was higher. So we don't want to use 0.4. Now, only today, we were talking about this. So in cardiac, the dose is 0.5.
0.5, yeah.
But
no, but cardiac is different. No, they are not.
Yeah. No, I'm just saying that, in cardiac, the dose is 0.5 mg per kg. So, for 60 kilo man, they're using 30 mg. We are using 0.25. So I think it's pretty safe. And I think now 0.25, I think, is becoming standard therapy.
But having said that, we have to be careful about tenecteplase also, because bleeds can happen with tenecteplase.
Of course it can happen. Of course it can happen. There's no doubt that it can happen. I mean, it's not foolproof by no stretch of imagination.
So any other question from the audience or from moderators? It's already 9:19. We have done for 1 hour and 20 minutes. If there's any other question
My God,
or
we can
comments.
talk forever on this.
So, I'm not finding any other question. Any other
Sorry to
comments?
interrupt, sir. We have one more question to ask, please, from Chennai. Yeah.
Sure.
So this is regarding the cognitive outcome that you said. It does not make a difference with regards to tenectase versus atiplase. I just want to know whether it was related to the amount of white matter lesions which were present prior to the stroke, which has caused the impact on the cognitive, because we do not know the cognitive status of the patient prior to the stroke. Whether this was
I
looked
don't
at.
know. I have not gone into that study detail in so much of this thing. But what impression I got, from superficial reading of that study was that it's not enough only to see the motor function and sensory function. In every patient, you should see cognitive, and cognitive does go down. A lot of brain tissue, infarcts do occur, cognition does go down. And we unfortunately, we are not assessing, with our psychologist, or, we don't have time to do it ourselves. But if you do it, I'm sure it goes down. I'm sure it goes down. It may go down de novo, even without white matter changes, if enough cerebral tissue is damaged. I mean, it does go down.
No, Chapuria, the point here is that cognitive functioning is taken now as one of the endpoints.
It should be taken.
Not only motor,
we are only
MRS.
taking MRS, but we must take cognitive also as an endpoint. I think it's very important. It's neglected, people don't have time to do it, and that's the problem. But cognition, very important.
Sir, I'm Dr. Makaran Dirve. We have one question from Bhopal by Dr. Garima Pandey. She want to ask whether there is increased risk in bleeding risk after tenecteplase if patient has already got the loading dose of antiplatelets. Sometimes patient get a loading dose of 300 milligram of aspirin before coming to hospital, and thereafter if he is being thrombolized with tenecteplase. So is there going to make any difference in the bleeding risk?
Bleeding risk will go up, but it's not a contraindication. Risk is more, but it's not a contraindication.
Correct. The risk is more, but it's not very substantially more.
Yeah.
But it's there.
Yeah. So don't withhold, I mean, see, I've always been saying that find a reason to give and not an excuse not to give.
Don't withhold even if you have given double antiplatelet. Don't withhold even if you are given one shot of low molecular.
Don't find there are people who will find 100 excuses. Aisa hua. No. Find a reason to give rather than an excuse to not to give.
Yeah, it's because of the fear of bleeding that.
Yeah, we are scared about bleeding. But withholding effective treatment is also a big risk. What about that?
Correct.
Yeah.
Hello, I'm Dr. R.K. Pandey from Lucknow. I have one more question. What to do, especially in patients who are elderly, like more than 80 years of age? Whether to use any thrombolytics or not, or which to prefer, alteplase or tenecteplase?
Dr. Subhash?
So the question is, in elderly, what is the difference? I think Chapuria just now said that there was no difference between tenecteplase and alteplase in elderly. And as far as elderlies are concerned, there is no contraindication you can give to anybody. We have recently thrombolized one patient who was 99 years old. But in literature, I have seen people of 104 also being thrombolized. So that age is not a problem. Upper age limit is not there at all. You can thrombolize anybody. And now the lower age limit also is slowly dissolving. I recently attended a meeting in Chapuria in Mumbai. And I was surprised that they are saying even in pediatric stroke also you can thrombolize. I have to check that literature. But they quoted some guidelines, European guidelines, that pediatric strokes also can be thrombolized. So age, I think, is no longer now any issue. Thrombolysis. You can thrombolize any age. So Dr. Pradeep, you have any other comment?
Fine. See, ultimately, as has been told, no, the idea should be always try to give the molecule. Try to give it and salvage the brain rather than restricting yourself because of some reason or the other. Because it is a perfectly safe molecule and really symptomatic intracerebral hemorrhage is very less with this molecule. Very less. I'm yet to have a really good, big symptomatic intracerebral hemorrhage in my patients. I've been using it extensively actually. So be bold enough to give it. Don't hesitate. That would be my this thing.
One of the predictors of bleed I have seen is uncontrolled, unsuspected hypertension, unsupervised hypertension. That happens sometimes in ICU during the night. And we have actually seen in patients who have bled, we have seen the BP chart during night. At some time, the BP has not been supervised. It has gone to 180, 190. So it's very important to make sure that your BP is well controlled, and that is a safety measure. So I think we have covered, Dr. Ichapuria has very nicely covered all the important points of the European Congress, and we have had good discussion. Dr. Pradeep, thank you very much for pitching in. It's 9:26, and I can hand over to organizers now.
So thank you, sir. Thank you, Dr. Ichapuria, sir. Thank you, Dr. Subhash sir, for the session.
Dr. Kaul, sir.
Yes, sir.
Just one small query. Any data or experience of using tenecteplase in pregnancy?
No, I have not used in pregnancy, but I don't think it's a contraindication. Alteplase is not a contraindication, so this also should not be a contraindication, but I have not used. I think Ichapuria can answer.
Yeah, I've used, the thing is, we've used Alteplase.
Alteplase I have used.
Yeah, but you see, Alteplase molecule is very large and it does not cross the placental barrier. So it doesn't go into the fetus. But one has to, have caution. It can produce bleeding into the placenta, but it's not a contraindication. I would say it's not in the guidelines, but it is good practice, whatever it's called, good clinical practice. So taking patient into confidence, because it's not in the guidelines.
The question is about
how will it come in
tenecteplase.
the guidelines? See, you have to do a big trial of some 1,000 patients for it to come in the guideline. How can it come in the guideline? It can't come in the guideline.
He's asking about tenecteplase, not about alteplase.
No, tenecteplase, I don't know. Alteplase I have used.
Thank you, sir. Thank you.
Yeah.
So,
thank you.
Over to
so
organizers.
Much, thank you, sir, for giving a very comprehensive lecture on the ESOC updates, especially emphasizing on the efficacy of tenecteplase in all subgroup and giving the updates for ESOC. And also thanks for giving the glimpse of ongoing interesting trials, especially in difficult to treat patients and the future updates of the trial. And also thank you very much for answering the questions. I also thank the audience here for being very interactive and for your curious questions. We had almost 710 logins in this webinar.
How much?
Via online. 710, sir.
710,
yes.
My God.
And then and 200 physical audience in this program. So it was a huge success for program. I would also like to thank the panelists and moderators who are present at the respective physical locations, and I may name them: Dr. Narang from Lucknow, Dr. Rahul Kulkarni from Pune, Dr. R.K. Pandey from Lucknow, from Dr. Manish from Mumbai, Dr. Pratim Chatterjee from Kolkata, Dr. Advani from Amravati, Dr. Ravi Shankar from Vijayawada, Dr. M. Pradeep from Kerala, Dr. T.C.R. Ramakrishnan from Coimbatore, Dr. Arun Kumar Agrawal from Jaipur, Dr. Narendrian from Madurai, Dr. Makarand from Bhopal, and Dr. Jayanti ma'am from Chennai, Dr. Anand Diwan from Nashik, and Dr. K. Ashokan from Coimbatore. So I thank all the respective moderators at their respective locations for also being part of this discussion and leading the discussions at the respective locations. And ultimately, I also like to thank Dr. Subhash Kaul sir, Dr. Chapuria sir, and Dr. M. Pradeep sir also for adding his valuable insights in this webinar and making this a very successful scientific initiative and which led to a lot of improvement in the knowledge for all the delegates and participants, especially on the ESOC updates, which are very extensive in nature. So with this, I thank all the faculty, all the delegates, all the participants, and RX Prism for organizing this successful event. And thank you and good night.
Good night.
Good night. Bye.
Thank you, sir. Thank you.
Thank you, sir.
Thank
Good night.
you.
Thank you, sir.